Thank you. Good morning, everyone. I am Haley Kadani, associated with INTA's Celestial Division, and I welcome you to yet another live webinar of Mumbai Hematology Group, led ably by Dr. M.B. Agrawal, sir. This webinar and such other hundreds of webinars have only been possible with the consistent support and encouragement from Dr. M.B. Agrawal, sir. He needs no intro and he is the teachers of teacher. India is fortunate to have him and he has enriched us by collaborating with stalwarts in hematology across the globe. Across the globe and bringing them on virtual platform every weekend since last 3 years. He has been awarded the Inspiring Hematologist of India by Economic Times. The topic of today's webinar is hematology of rheumatological disorders. Today's webinar will be moderated by Dr. Amit Khurana, sir. Dr. Khurana is hematology, hemato-oncology, and bone marrow transplant physician associated with Akanksha Hematology Center, Surat. He is fellowship in clinical hemato-oncology and bone marrow transplant from Singapore with 10 years of experience of serving over 10,000 hemato-oncology patients. He is trained in all benign and malignant hematological conditions. We welcome you all to this live webinar, and I would now request Dr. Amit Khurana, sir, to initiate the proceedings of the webinar. Thank you, everyone.
Thank you so much. Let me share the screen. Can you see my screen?
Yes, sir.
Okay. So very good morning to all of you from this part of the world, and good afternoon and good from whichever part of the world you are from. Today, our guest speaker of the day is Dr. Punit Mashru from Mumbai. He is going to lecture us on hematology of rheumatological disorders. This webinar is brought to you by Mumbai Hematology Group, supported by INTAS, and very well managed by Perfect Square. I thank Mr. Arun Chanda, Dr. Manoj Kumar and team INTAS, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Professor Yojana Gokhale from Mumbai, our guest speaker for the day, Dr. Punit Mashru, rheumatologist, Mumbai, all our discussants who are themselves eminent rheumatologists or hematologists, and you participants for sparing your Sunday morning, afternoon, or evening from whichever part of the world you are from. Let me try to introduce all our discussants today and their galaxy of them. To start with, we have Dr. Abhishek Dudatra from Ahmedabad, Dr. Abhishek Patel from Bengaluru, Dr. Abra Chaudhary from Kolkata, Dr. Aditi Shah from Mumbai, Dr. Aishwarya Raj from Ahmedabad, Dr. Akanksha Garg from Jodhpur, Dr. Akhil Goyal from Jaipur, Dr. Akshaya Mandloy from Kolkata, Dr. Arya Chattopadhyay from Kolkata, Dr. Aruna Bhatt from Bangalore, Dr. Bharat Singh from Jaipur, Dr. Bimlesh Pandey from Noida, Dr. Chandrakala S. from Mumbai, Dr. Chandrika Bhatt from Bengaluru, Dr. Deepika Ananda from Bengaluru, Dr. Gayatri Ekbote from Pune, Dr. Jyotsna Kulkarni from Mumbai, Dr. Kaushik Bhojani from Mumbai, Dr. Kunal Goyal from Mumbai, Dr. Madhumita Das from Guwahati, Dr. Begna Gawali from Hyderabad, Dr. Nidhi Dixit from Kolkata, Dr. Pramod Chebi from Dharwad, Dr. Pooja Srivastav from Gujarat, Dr. Ritasman Beswa from Hyderabad, Dr. Rohini Samant from Mumbai, Dr. Sakir Ahmed from Bhubaneswar, Dr. Santosh Mandal from Kolkata, Dr. Shailaja Sabnis from Mumbai, Dr. Shilpa Gupta from Mumbai, Dr. Shweta Bansal again from Mumbai, Dr. Somya Jain from Saharanpur, Uttar Pradesh, Dr. Saurabh Malviya from Indore, Dr. Sundeep Grover from Meerut, Dr. Sunit Lokwani from Indore, Dr. Sunita Kaidi from Hyderabad, Telangana, Dr. Subramaniam Nelasriyaman from Madurai, Tamil Nadu, Dr. Yojana Gokhale from Mumbai. And it's our time now to introduce our special guest of the day, Dr. Professor Yojana Gokhale. Dr. Yojana Gokhale is Professor of Medicine in charge of Rheumatology at LTM Medical College, Science, Mumbai. She is President-elect Maharashtra Rheumatology Association. Professor Yojana Gokhale has experience in the field of rheumatology of over 30 years. She has over 100 publications and presentations in national and international journals, conferences, and book chapters. Her special interests include SLE, vasculitis, and arthritis. She has organized national-level rheumatology CMEs. She has started rheumatology fellowship in Lokmanya Tilak Municipal Medical College, Science, Mumbai. Her original research has been on brucellosis arthritis, celiac disease, and osteoporosis, etiology of digital gangrene, non-healing leg ulcers, and non-ischemic cardiomyopathy. It's my pleasure to invite her to inaugurate our webinar and give some words of wisdom. Over to you, Professor Dr. Yojana Gokhale.
Thank you so much for your kind words, Dr. Kalpesh. And good afternoon, everybody. Thanks for joining today's meeting. We have very exciting topic, hematology of rheumatic disorders. Actually, most of our rheumatology patients, they present with aches, pains, fatigue. And in addition to detailed history and examination, a simple hemogram, SED rate, and urine examination gives us a clue to correct diagnosis in most of the patients. In addition to actually finding out the correct diagnosis, hematology really helps us in monitoring our patient to finding out complications in a given case. Now, suppose you're sitting in an OPD and there is a patient, a 60-year-old lady who comes with aches, pains, fatigue, for which she has been taking some Ayurvedic alternative medicine. You find that hemoglobin is 8, ESR is 90. Wouldn't it be interesting to actually and challenging to actually find out if she has rheumatoid arthritis or Sjogren's or polymyalgia rheumatica, myeloma, or some underlying malignancy? Is my time over?
No, ma'am, please go ahead. Please go ahead.
Okay, because something clicked, so I really couldn't make out. Okay, fine. So in addition to, it could even be, anemia of chronic disease because of some underlying malignancy. Cytopenia is again, like a thrombocytopenia could be first presentation of SLE. In a patient with aches and pains, actually, when there is a cytopenia, we think of lupus, whereas when there is a leukocytosis or thrombocytosis, we err towards diagnosis of rheumatoid arthritis. Once in a while, in a busy OPD, you may have somebody with acute bone pains because of sickle cell disease, avascular necrosis, and of femur head. And then sickle cell disease, if you some undiagnosed sickle cell disease and first presentation as bone infarct, you made the diagnosis, your day is made. And the vastness of today's topic is so much that, autoimmune coagulopathies like antiphospholipid antibody syndrome may present with dysfunction of any organ, right from skin, digital gangrene, ulcer to affection of the brain leading to cerebrovascular accident or cortical venous sinus thrombosis. And if it is an accelerated variety, like catastrophic presentation, then timely diagnosis and treatment is life-saving. So the whole branch of rheumatology as well as hematology, they may look like very cold branches to you, but they are very, very interesting and challenging branches. And your timely correct diagnosis can really save a life. And as if this is not enough, there is a new kid on the horizon, immune checkpoint inhibitors, which are used nowadays for treatment of hematologic malignancies also. So they basically release breaks in the immune system, and that makes the natural killer cells active in killing the tumor cells. But by the very mechanism of action, they cause immune-related adverse events, arthritis, vasculitis, Zika. So actually, the expanse of today's topic is so vast that at the end of today's meeting, I'm sure the trainees would really be interested in taking up rheumatology or hematology as their career choices. India needs 10,000 rheumatologists, whereas we have only 1,500, and every year we add only 50 more. And I'm sure similar must be the case for even hematology. So there is tremendous scope for rheumatology as well as hematology in the country and a very bright future. I think without any further ado, I pass on mic to our speaker. Over to Dr. Punit Mashru.
Thank you so much, ma'am, for that words of wisdom. This is really inspiring for all of us, not only in the field of rheumatology, but also in the field of hematology. Let me share the screen again. Yeah. So thank you so much, ma'am, once again. It's now time to introduce our guest speaker of the day, Dr. Punit Mashru from Mumbai. Dr. Punit Mashru is consultant rheumatologist, additional director, Jasnok Hospital, Sir H.N. Reliance Foundation Hospital, Breach Candy Hospital, Mumbai. Dr. Punit Mashru is a consultant rheumatologist and additional director at Jastlok Hospital, consultant rheumatologist at Sir H.N. Reliance Foundation Hospital and Breach Candy Hospital, Mumbai. He has done his fellowship in rheumatology from PD Hinduja Hospital and Christian Medical College, Vellore. He is also certified clinical densitometrist by ISCD USA, which is a certification for DEXA scan interpretation. He has authored chapters including DEXA interpretation in the Indian Manual of Rheumatology textbook, Pregnancy and Vasculitis in the textbook of Women Issues in Autoimmune Diseases, Microscopic Polyangiitis in the textbook of Vasculitis, to name a few. He has published various research papers, case reports in Indian and international journals. He will be lecturing us today on hematology of rheumatological disorders. Over to you, Dr. Punit Mashru. Thank you so much.
Thank you for the kind introduction. Kindly excuse my voice. I'm just recovering from a post-viral laryngitis. So I'll be presenting. First, thank you. I would like to thank Dr. M.B. Agrawal sir for inviting me to speak. I'm very thankful to that. So I'll start with my presentation. Let's share my screen. 1 minute. So my today's presentation is going to be case-based presentation. I think I've got 4 or 5 cases, very interesting cases, in which we can have a lot of discussion on. So start coming with the first case. Am I audible first?
Yes, you're audible.
Right. So 24-year-old female, so this is a girl, this is a lady who basically I've seen once, and she was predominantly managed elsewhere, and I was referred once to rule out autoimmune condition. So she's a 24-year-old female. She had history of left-sided CVA in 2021 when she was pregnant, 14 weeks pregnant, and an MRI brain was done, which showed an acute left ACA stroke. At that time, she was rightly evaluated, and she was found to have triple positivity of her APLA. So she had lupus anticoagulant, ACLAS, IgG, IgM positive, and beta-2-glycoprotein 1 IgG. She had no other previous history of miscarriage, and she was rightly started on Clexane and aspirin. Now, when a female is planning pregnancy and they have triple positivity, their outcomes are not great. In one study, only 30% of patients had a live birth. And here she's somebody who had a stroke and had triple positivity. So she was counseled, but she wanted to go ahead with the pregnancy. They managed to get her through. So she was 35 weeks pregnant. They got an LSCS done. And post delivery, she was continued on Clexane, and then she was started on Dabigatran. She was readmitted on 22nd March this year with ecchymotic patches. This was a CBC, and her platelet count was low, 22,000. Her peripheral smear was negative for schistocytes. And you can see it had dropped down to 4,000. So at this point, she was admitted under a physician who started on IVIG 2 grams per kg. And that's when I was referred. So basically to lot lupus. Her ANA was positive, but all of the antibodies we had worked her up was negative. She had no proteinuria, nothing else. She was with IVIG, the platelet count didn't really much improve. And then she was pulsed with methylprednisolone. She was then started on Eltrampovac, which is thrombopoietin receptor agonist. And then on the platelet count was not much improving, though not much of time was there. But on 31st of March, she was given rituximab. So she was in the hospital for quite a bit of time, and She wanted to go back to her kids, and so she took her discharge against medical advice, and she was discharged on prednisolone 60 milligrams. She was readmitted on 5th of April with complaints of left-sided weakness and headache. Her platelet count was normal, and an MRI was done, which showed a right MCA distribution, complete acute non-hemorrhagic infarct. So she was stopped, dabigatran was started, and entombag was stopped. And rituximab, another one dose was given on 15th of April. And then the platelet count normalized. She is now sort of recovered. So I've seen her twice. So last I saw was 1 month back and once during the admission. So antiphospholipid antibody syndrome, basically, this is a classification criteria, which includes lab criteria, lupus anticoagulant, ACLA, anti-beta 2 glycoprotein 1, IgG, IgM, with either a thrombus in the form of arterial venous or small vessel thrombosis confirmed by imaging, or a pregnancy-related morbidity in the form of unexplained miscarriages of more than 10 weeks of gestation with a normal fetal morphology documented by ultrasound or direct examination of the fetus, or premature birth before 34th week of gestation due to eclampsia or preeclampsia or placental insufficiency, or more than 3 unexplained consecutive miscarriages less than 10 weeks without any anatomical, hormonal, or chromosomal alterations. In terms of the clinical significance, lupus anticoagulant is the most significant in terms of the effect, followed by anti-beta 2 glycoprotein 1 and anti-cardiolipin antibody, and then the others. IgG is more clinically significant than IgM and IgA. As you can see, lupus anticoagulant has highest risk of thrombosis compared to the other antibodies, and triple positivity is highest. There are also non-criteria manifestations of this condition, which are not part of the classification, which include seizures, transverse myelitis, chorea, cardiac involvement in the with basically valve involvement, ITPs, APS nephropathy, to name a few, and libido reticularis. This is a classical libido reticularis, but there are other conditions also associated with this symptom, that one needs to keep in mind. So our patient was started on the newer anticoagulation. So I think there's a lot of discussion. I will start with the first thing. So the new anticoagulation have been first approved by the US FDA in 2010. It is safe and effective alternative to VKA or LMWH in treatment of VT and PE. And there are 2 classes: oral direct factor 10A thrombin inhibitors or direct thrombin inhibitors. There are quite a few advantages in terms of there's fewer monitoring required, less follow-ups, and predictable anticoagulant effect, and less food interactions. Now coming to dabigatran first, our patient was started on dabigatran. So what is the evidence that it can be used in APS? So in these 2 studies where they covered over 6,800 patients, there was 151 patients of APS at baseline. And what it showed was that in patients of VTE, there was no difference in terms of thrombotic events between dabigatran and warfarin. Also, what was noted is that the bleeding events were lower in the dabigatran group compared to the warfarin. This is a TRAPS trial where rivaroxaban was used in high-risk APLA positivity, triple positivity, and it was stopped early because of increased events. So it was in 19% in the rivaroxaban group compared to 3% in the warfarin. What about the lower risk? What was seen was that even in the lower risk category also, there was increased risk of thrombosis in the rivaroxaban group, the 11.6% compared to 6.3% in the VKA group. But if you look in the fine print, they were all arterial events. There was no increase in venous events, and the safety parameters were equal on both of them. Apixaban, this is a recent trial which has come out. So 48 patients of APLA, 23 on apixaban and 25 on warfarin. Initially, they were given 2.5 milligram BD, but they had 3 patients who developed a CVA and later had to be increased to 5 milligram BD. And in spite of increasing 5 milligram BD, there were more patients that had strokes. As you can see, the definite difference more thrombotic events in patients of apixaban. And again, all of them were arterial events. So this is a meta-analysis where 447 patients of APS were treated with these new agents, which included 290 patients of rivaroxaban, 144 patients of dabigatran, and 13 patients of apixaban. In that, 16% patients experienced recurrent thrombosis while on these agents. The rates of recurrent thrombosis was 16.9% and 15% in anti-10 inhibitors or dabigatran respectively. Triple positivity was associated with fourfold risk of recurrent thrombosis. And in patients treated with anti-10 inhibitors, history of arterial thrombosis was associated with higher risk of recurrent thrombosis. This is a beautiful slide. This was a review that was done reviewing all the guidelines of APLA and the newer agents and anticoagulation. So if you have a patient who has a arterial thrombotic event, the recommendation is hands down, have to use VEXAS. In triple positivity with venous or thrombotic or arterial thrombotic events, again VEXAS. If a patient has venous thrombotic event with triple positivity, again VEXAS. But if they have a single or double positivity, VEXAS again is the first choice. But one may consider the newer agents in these in this certain subset. So if it is lupus anticoagulant positive, again, I think VEXAS would be we should insist on VEXAS. Coming to APLA-associated thrombocytopenia, as our patient had, the incidence is between 20 to 30%, but severe thrombocytopenia is rare and bleeding is infrequent and occasionally can be the first manifestation of APLA. So we need to do the APLA workup when a patient with ITP comes, and it does not protect against thrombosis. So that's very important. In 1,000 patients, you can see that the incidence was around 21%. Okay, so in patients who are of APLA with thrombocytopenia versus without thrombocytopenia, is there any difference in terms of risk of thrombotic events? And the answer is no. Both had equal amount of thrombosis. And LA was associated with the higher risk in these patients. So management of these patients in mild, moderate, more than 50,000, we just monitor them. If it's less than 50, then corticosteroids along with immunosuppressive agents. I'll come a little bit into that. This is a good slide which showing the initial response to different therapies and the peak response time period for these therapies. So Eltrombopag in one study has been used in resistant ITP with underlying CTD. So 15% of 15 patients who had failed treatment, 80% of them responded to this therapy. But we have to be careful in patients of APLA, of patients who have antiphospholipid antibodies bodies, because there's in this study there was an increased risk of thrombotic episodes in this subset of patients. In resistant ITP, rituximab is very effective. So 91% of patients with ITP, 87.5% with autoimmune hemolytic anemia, and 60% of Evans syndrome had responded. There is also some newer studies that are going on with combination of rituximab with belimumab, and one study showed it had good effect of around a response of around 80%. So isolated ITP can be a presenting feature of lupus, and it can precede other aspects of lupus by months or even years. In one series, it was noted around 12% of patients of ITP go on to develop SLE. Antiphospholipid antibody syndrome can have multiple presentations and can range from asymptomatic to thrombotic to obstetric. So coming to the treatment of asymptomatic carriers. So if a patient with high risk APL profile, the recommendation is to give low dose aspirin, because studies have shown that there's a reduced risk of thrombosis, first reduced risk of thrombosis in these patients. You can see if patients who have asymptomatic APLA positivity over a period of time, they are at risk of getting thrombosis. In all our lupus patients, we must look for antiphospholipid antibodies, because if they are positive, then we may consider adding low-dose aspirin, especially if they have the lupus anticoagulant or they have a high-risk category. Once they had an arterial, if they have had an arterial event, then the recommendation is warfarin with an INR of 3 to 4, or INR of 2 to 3 with low-dose aspirin, or if it's a venous event, then an INR of 2 to 3. In spite of this, if they have recurrent thrombosis, then, and if the INR wasn't target range, then we aim for a higher INR, or we change to low molecular heparin, add hydroxychloroquine. In lupus, it's shown to be effective. In APS, the studies, the data is not clear. One may add statins, and there are some case reports of immunosuppressive being used. So what if we stop patients who have got a thrombotic event, and if the APLA antibodies become negative, the risk of thrombosis is still there, and even in spite of the antibodies disappearing. So the recommendation is that these patients should be on lifelong anticoagulation. The caveat is that if you have a patient who has a low titer APL, like a ECLA, low titer ECLA or something of that sort, and has had a precipitating event which you can identify, then one may consider stopping after discussing with the patient. Catastrophic antiphospholipid antibody syndrome is very rare. It's less than 1% of all patients. It is a rapidly developing widespread thrombosis with multi-organ failure, often triggered by some other surgery, infection, pregnancy, delivery, etc., and carries a high mortality despite adequate treatment. This is a classification criteria for CAPS. So evidence of involvement of 3 or more organ systems or tissues, development or manifestation simultaneously or in less than a week, confirmation by histopathology of small vessels, and lab confirmation having the APLA positivity. If they have all 4, it is definite CAPS. If they have 3 with definitely have to have the APLA antibodies, then it can be probable CAPS. But this criteria is not in the real world setting. It is sometimes challenging because you can't get often these patients are so sick, we can't get a tissue diagnosis to confirm small vessel occlusion. We can't repeat the APLA antibodies. The patient is quite critical. In what was also found that 82% of patients with in the CAPS registry had positive lupus anticoagulant. In terms of differential diagnosis, CAPS, TTP, DIC, HELP, SRC, and HIT needs to be kept in mind. Differentiating from TTP can be a challenge, but what is important is that pulmonary involvement is less in TTP, and obviously, yes, and okay. In terms of etiology and associations, the infection is most important, followed by malignancy, surgery, and subtherapeutic anticoagulation. These are the sites where infections, in terms of the sites of infections. These are the sites of organ involvement in CAPS. Treatment of CAPS is triple therapy. So combination of anticoagulation, steroids, plasma exchange. Plasma exchange is not there, then IVIG. Because anything less than that, the mortality is very high. There have been case reports where rituximab has been used in the CAPS. 75% of these patients had responded. And there have been case reports of other agents being used.
Dr. Puneet?
Yes.
Just your slides are not visible actually. I think.
Since when?
That is what I'm getting the messages from everywhere.
Oh.
So can you please
make it visible for us?
Yeah, not visible to other people. Just
no, one person is not visible. Everybody else is visible.
We can see.
You can see.
We can see.
We can see.
Okay. Share. Then go ahead, please. Yeah.
Okay. In obstetric APS, if the patient has confirmed obstetric APS, then combination of low-dose aspirin with prophylaxis of heparin should be used. In patients who has history of thrombosis or pregnancy failure while being on the OD dose of heparin, then we should give them full anticoagulation. In registrant cases, again, hydroxychloroquine, prednisolone for 10 milligrams for 3 months, pravastatin IVIG has been used. TTP, which is life-threatening condition, typically manifested by pentad of thrombocytopenia, fever, MAHA, neurological manifestation, and renal impairment. And again, these patients needs to be managed with plasmapheresis. As you can see that patients who are given only steroids or no treatment, the mortality is high. So the treatment is a plasma exchange daily for 5 days with pulse steroids. And in cases of lupus, we must give them rituximab or cyclophosphamide. Scleroderma renal crisis is one of the cardinal vascular manifestations of scleroderma. It is not an inflammatory process. It's basically a high renin state, and 10% of patients of scleroderma may develop SRC, and usually it is in the first 3 years, and they have diffuse skin involvement. And occasionally, rarely, it can occur before the onset of skin changes, which may make the diagnosis challenging. These are the risk factors, as it mentioned: diffuse skin involvement, tendon friction rubs, the antibody positivity of anti-RNA polymerase 3 antibody, new onset anemia, pericardial effusion, and recent dose of prednisolone of dose of 15 mg or more. Anti-centromere antibody patients may be protected. This is a proposed criteria for scleroderma renal crisis where the blood pressures are high, though 10% of patients can be normal. Evidence of kidney injury, 43% of patients of scleroderma renal crisis can have microangiopathic hemorrhagic anemia and thrombocytopenia, organ dysfunction, and renal pathology. You may want to sometimes rule out associated conditions like ANCA vasculitis. The treatment is giving ACE inhibitors and not immune suppression in these patients. So short-acting ACE inhibitors and reducing the blood pressure quickly and getting to a goal of 120/70 within 72 hours. If you're not able to achieve it, then adding calcium channel blockers. We should avoid diuretics, and prostacyclins may help in some patients. But we should continue this treatment because many of these patients would recover, and it takes sometimes up to 2 years to recover. The 2-year mortality is between 26 to 34%, but 25% of them require permanent dialysis. Indian data is sparse because in the labs we don't have this anti-RNA polymerase available, and in one single control study by Dr. Aman Sharma had shown that mortality was 85%. Okay, so continuing to the next case, this is 32 female, case of lupus with mucocutaneous and arthritis, and she was diagnosed in 2017, and she had defaulted treatment. She was admitted under gastro with complaints of 2 months of severe abdominal pain, vomiting, nausea. She had loose motions, and she had low-grade fever on and off since 2 months, but then since on admission, she had high-grade fever. She had anorexia, weight loss. She had she didn't have any history of melena, flesh bleeding. And you can see she had active lupus. She had malar rash, palatal ulcers. She had ascites. And these were her labs. So before the admission, you can see that, so she has ESR high, CRP is borderline high. Her WBC is on the downward trend a little bit, and her LFTs are deranged. She had abdominal pain, so she was evaluated, and her CT abdomen had showed target sign, so, and bilateral hydronephrosis. So she had GI vasculitis because of lupus. You can see the thickened edematous bowel loops and ascites. So you can see the trend of the counts that her WBCs were going down, ESRs normalizing, CRP is going up, LFT is getting deranged, and ferritin being very high, triglycerides high, fibrogen low. She had active sediments in the urine. She had active proteinuria. Complements were low. So she is a case of, she had very active disease of lupus along with GI vasculitis and macrophage activation syndrome. In lupus, generally we use CRP to differentiate from active disease and infection. In infection, the CRPs tend to be high, but in CRPs, in disease activity, it will be normal. When you get cytopenias and your cultures are negative, everything negative, and you have cytopenias in lupus with high CRPs, masses, that's something needs to be thought about. Also, the fever pattern in lupus is generally low-grade fever. Your change in the intensity of fever is a strong clue. So what we did was we pulsed the patient with methylprednisolone for 3 days. We started cyclosporin upfront, 2 mg per kg, and we titrated the dose. And she sort of, the count started becoming better, but overall the disease was quite active. She had continued abdominal pain. So we went and gave her cyclophosphamide after a week or so. Coming to another case, a 41-year-old male, no comorbidities. He had fever on 13th of July. He had some sore throat, moderate to high-grade fever. He had some joint pains involving ankles and was quite painful. So I had seen a physician who had started NSAIDs and he was not better. So he started on hydroxychloroquine and sulfasalazine. On stopping the NSAIDs, he again had fever and he was not doing well. So he was admitted to the physician. And you can see the labs that he had leukocytosis, thrombocytosis, ESRs were high, CRPs were high, OTPT was deranged, rheumatoid factor and chikungunya, all those things were negative. So the physician sent the cultures, started on broad spectrum antibiotics, and sent off different tests. In that, the ANA came weak positive, so I was called. And when I asked him, he had history of intermittent rash on and off on the trunks, on the trunk and palm and the thighs since a week, but he had no other symptoms of connective tissue disease. He had some synovitis on the ankle, which was painful, and you can see the rash. This is a 40-year-old male with fever, inflammatory arthritis, rash, associated fever, sore throat, leukocytosis, and deranged LFTs. So this patient clinically has Still's disease, but this is diagnosed with exclusion. So he underwent a PET scan, did not show anything, got a lymph node biopsy done. You can see the ferritin was slightly elevated, but CRP is high, ESR is high, WBC platelet counts high, and the NA blood come negative, but his fever then pattern changed, and it changed to a persistent fever. There was a toxic look. This was in contrast to what the previous time in between fevers he was appearing fine. And the labs, you can see that the WBC normalizing, platelet count normalizing, ESR is going down, CRP is going up, and ferritin of 17,000, elevated triglycerides and low fibrogen. So this was macrophage activation syndrome in Still's disease. He was treated with pulse methylprednisolone and started cyclosporin, and he improved. So HLH basically divided into primary and secondary, and when it is because of autoimmune rheumatological conditions, it is known as macrophage activation syndrome. Causes include systemic onset GI, Still's disease, lupus. Other diseases include Kawasaki, and other diseases also can cause macrophage activation syndrome. This is the incidence of Still's is around 12 to 15%. In systemic onset GI, it can be up to 10%, but subclinical mass can be observed in 40% of patients. In lupus, it can vary from 0.9 to 4.6%, and Kawasaki can be 1.1%. So in systemic onset GA, is primary HLH associated with different genetic abnormalities. So in a study, it was seen that 36% of systemic onset GA had mutation of one of these genes. It is important to go into the precipitating causes, which can be active disease, infections like EBV, and drug like sulfasalazine. Like in our patient in Still's disease, he was started sulfasalazine. That may have been a trigger for his MAS. In fact, in these patients in systemic onset JA and Still's disease, it is contraindicated. This is a review literature of MAS in the setting of systemic GI, and you can see the organ involvement. 35% of them having CNS involvement. And the mortality was around 8.1%. This is a review of lupus patients with MAS. With again, you can see a CNS involvement is around 18%. And that can be a challenge differentiating from neuropsychiatric lupus from MAS. Coming to diagnosis, so in patients of systemic GI and Still's disease, the change in fever pattern from a quotidian to a persistent, a rash from an evanescent rash to a persistent petechial rash, and normalizing of platelet count and other blood counts is important to pick up early MAS. When to pick up MAS and lupus is a change in fever pattern, as I discussed, is that they usually have low-grade fever. Unless they have RNP positivity, then they may have higher grade of fever. And again, dropping counts, drop in ESR and rising CRPs. Signs of active lupus include malar rash, oral ulcer, cytopenia, serositis, proteinuria, low complements. These are vasculitic rashes, so associated active disease. We all know the HLH 2004 criteria for diagnosis of HLH. So, but in patients of systemic GI, we may miss out or we may diagnose these patients late. So 2016, the ACR-ULR criteria came to diagnose these patients early, and that included a known or suspected patient with systemic GI with fever and ferritin more than 784 with any of the two of the following. So platelet count less than 1, like 81,000, AST more than 48, triglycerides more than 156, and fibrinogen less than 360. You can see that the cutoff for the platelet count and fibrinogen is definitely higher. This is the H score, which basically includes 3 clinical criteria and remaining lab criteria. And what it was found was that it has a good specificity, and an H score of less than 90 had there's 1% chance of HLH, and more than 250 had 99%. And if it's 169, then the specificity can be 86%. Ferritin levels in HLH in the HLH 94 studies, the ferritin more than 500 was noted in 93% of patients, more than 5,000 in 40%, 42%, and more than 10,000 in 25% of patients. And ferritin more than 10,000 has 90% sensitivity and 96% specificity for HLH in this group. A low ferritin does not exclude HLH. There are other causes of ferritin being more than 10,000 that one can keep in mind. They include neoplasms, fulminant hepatic disease, and idiopathic hemocentrosis. In systemic GI, a more sensitive marker may be a ferritin to ESR ratio of more than 80, which has been proposed as a biomarker. There are other biomarkers which are which is in research purpose at present. So a soluble CD25 of more than 7,500 can be used to differentiate from active systemic GI and subclinical MAS. CXCL9, CXCL10 significantly higher in systemic GI with a history of MAS compared to patients without a history of MAS. So it's identifying patients who are at risk of developing MAS. STT2 and CD163 to differentiate from MAS and primary HLH. Bone marrow is not compulsory to diagnose, as we may get it only positive in 60% of patients. Coming to the management, in autoinflammatory conditions, the first drug of choice is giving high dose of methylprednisolone with a combination of cyclosporin. One may use anakinra or other agents. I will come to that. If there is an insufficient response or CNS involvement is there, then etoposide may be used. IVIG may be used when there's active infection and the dose is 1 gram per kg over 2 days, and we may repeat it later on. But IVIG is rarely successful and used in combination with other medications. In this study, in this case series where IVIG was used initially in lupus patients with MAS, all the 3 patients did not respond, and they needed other therapies. In a review of systemic GI with MAS, where IVIG was given, initial, and 6 patients of them were given as an initial monotherapy, and none of them had responded. Only one patient, the addition of IVIG was added to steroids, resulted in remission. So it doesn't work very well. Anakinra is the first drug of choice in terms MAS associated with systemic GI and Still's disease. It is typically used in combination with other treatments, particularly steroids. Monotherapy can be used when we are concerned for infection or malignancy. And the dose is initially 1 to 2 milligram per kg and rapidly increased to 10 milligram per kg per day. In India, it is not that freely available. We can get it, we can acquire it, but it takes time for it to come. So in acute setting, it may be difficult to get. There are case reports of tocilizumab being used in MAS. Now, what if a patient who's on tocilizumab can develop MAS? So there's data where 23 patients out of 394 patients develop confirmed or probable MAS on tocilizumab. And when they develop MAS on tocilizumab, then it may mask the typical clinical features of MAS, and they may have a milder clinical symptoms and normal CRPs. With TNF inhibitors, there are case reports of it being used in systemic GI and Still's related MAS, but it may also trigger or worsen disease progression. Plasma exchange, there are some case series where it has been used as a bridge therapy, but not as monotherapy. Cyclophosphamide has been used in many of the case reports, and rituximab also has been used, especially when there are other organ involvements and we need to control the overall disease. Emapalumab is an anti-interferon gamma monoclonal antibody, which has been FDA approved for primary HLH. There are studies ongoing for MAS complicating systemic GIA, and 6 patients were in an abstract was presented, and this agent was used, and all of them had responded. Etoposide used in 8 patients of systemic GIA, and all of them had rapid recovery. Coming to the next case, so he's a 45-year-old male. He's a brother of a consultant working in the hospital, and so she got him to me saying that, look, he has Raynaud since May of this year, and he gets on and off pruritic rash since January. He's getting it of this year. Clinically, so in the history-wise, he didn't have any symptoms or suggestive of connective tissue disease. He had no systemic complaints, no history of any fever, weight loss. He had no history of asthma or any significant comorbidities or family history. He was a non-smoker, no history of tobacco. So when I examined him, his right radial pulse was feeble. All the other peripheral pulses were well felt. His peripheries were cold. System examination was normal. And this was his hand. So this wasn't like a Raynaud. It was like ischemia. And when I examined him, he also had a prominent temporal artery bilaterally, which was non-tender. The pulse was very feeble there. And when I saw that, I asked him specifically history of headaches or limb claudication or jaw claudication or history of PMR symptoms, any ophthalmic symptoms or ENT. And I looked for bruit or carotinia, which was not there. So giant cell arteritis, basically symptoms include headache, jaw claudication, scalp tenderness, loss of vision, abnormalities of temporal artery, claudication of arms, especially if subclavian is involved, constitutional symptoms, and PMR symptoms. So giant cell arteritis is also known as temporal arteritis. So, but there are non-giant cell arteritis causes of temporal arteritis, which we need to look at. So polyarteritis nodosa, Chooks-Strauss, ANCA vasculitis, cryoglobulin vasculitis, and rheumatoid vasculitis. So at that point, I felt this patient had polyarteritis nodosa. I got his labs done, and all his reports were normal. His eosinophil counts were high, but his inflammatory markers were normal. There was no proteinuria. This obviously wasn't a connective tissue disease. He had got his ANAs and all this done outside, which was negative. ANCAs were negative, cryoglobulins, APLA workup, complements, stool for parasites, everything normal. Got his Doppler done, which was suggestive of a low resistance flow in the upper limb, suggestive of a peripheral vascular disease. His right radial and left ulnar artery showed diffuse wall irregularity with reduced flow. And there was a short segment focal dilatation of the left ulnar artery at its origin. And there was an echogenic clot which was seen in the dilated segment. You can see the temporal artery ultrasound was done, which was showing thickening and suggestive of temporal arteritis. So we wanted tissue diagnosis. We got temporal artery biopsy done. And to my surprise, it showed predominantly eosinophilic infiltrates. There was no giant cell involvement, nothing else, just eosinophilic arteritis. So at that point, I got a whole body PET scan done. I wanted to look at the large vessels, whether the large vessels involved, which was normal. I was interested, is any paraneoplastic etiology happening? And also wanted to look for any lung lesions or sinus lesion, which you see in Chuk's, which was not the case. His PET scan was completely normal. With hypereosinophilia, echoes are very important. So the echoes were done, which was normal. MR angio was normal. This was a brother of a doctor and was very anxious. She wanted to see other vessels involvement. So she got a CT abdominal angiogram, which was normal. And I got a lung function test, which was normal. Because everything came back normal, I involved the hematologist and got additional testing done. So the genetic testing, PD, GFR, A and B was negative. So in terms of our differential diagnosis, giant cell arteritis, but the age is odd. He's young. Upper limb involvement resulting in a digital ischemia is uncommon. And temporal artery did not show the granulomatous giant cell formation. In fact, it was just eosinophils. The other differential is Chuk's, where you have 4 or more, and history of asthma, eosinophilia, mononeuropathy, migratory or transitory pulmonary opacities, paranasal sign involvement, and biopsy showing accumulation of eosinophils in the extravascular areas. But there's no history of asthma. In fact, these patients have worsening asthma and allergic symptoms. But that was not the case. There was no lung sinus involvement. And there was no granulomatous giant cell formation seen on the temporal artery biopsy, and his anchors were negative. This is the classification criteria for vasculitis, which include large, medium, small vessels, variable vessels, single organ involvement, vasculitis associated with systemic disease, and vasculitis associated probable etiology. In this classification, there's no mention of hypereosinophilia related vasculitis. My diagnosis was medium vessel vasculitis secondary to hypereosinophilic syndrome. He was seen by a hematologist. Bone marrow was discussed, and patient was not that keen, and there was nothing in the smear or the CBC to suggest anything else. So with the clearance from the hematologist, I went ahead and pulsed the patient with methylprednisolone for 3 days, followed by an angio-EKG. He had a short course of anticoagulation, and he improved. His eosinophils counts have come down. Currently, he's on taping dose of steroids. Currently, he's on 10 mg of steroids, and he's following with Dr. MV, I think Dr. MV also. So diagnostic criteria for hypereosinophilic syndrome includes blood eosinophilia of more than 1500, no other apparent cause for eosinophilia as parasitic infection or allergic disease, or signs or symptoms of eosinophil-mediated end organ dysfunction. Hypereosinophilic syndromes can rarely involve vascular systems leading to eosinophilic vasculitis that affects not only small vessels but also medium-sized vessels of the limbs. It is classified into primary, which is neoplastic, secondary, reactive, or idiopathic. Primary is myeloproliferative or lymphocytic, and reactive can be because of eosinophilic asthma or other allergic or non-atopic diseases, infections like parasites, fungal, autoimmune disease like connective tissue disease, sarcoid, IBDs, systemic vasculitis, especially Chuk's, hemat and solid neoplasias, and organ-restricted hypereosinophilia. So when we get a patient of hypereosinophilia and vasculitis, if they have active asthma, then EGPA is likely. If there's no asthma, then we work up for vasculitis by getting ANCAs and cryoglobulins, rule out other causes, viral markers. If they all are negative, then do genetic studies and look for neoplasias, and if they are negative, then this patient likely has eosinophilic vasculitis. This is the incidence of the different organ involvement, and cardiac being extremely important, cardiomyopathy and constrictive pericarditis. The treatment depends upon whether the PDGFR gene is positive or negative. If it's negative, prednisolone hydroxyurea can be used. And if lung involvement is there, methotrexate can be used. Mepolizumab is a monoclonal antibody against IL-5 and has been FDA approved for hypereosinophilic syndrome. And the study it is shown to be effective. There are case reports of other agents being used, tofacitinib and ruxolitinib. And if mepolizumab is not available, then maybe one may use interferon alpha. Coming to the next case, this is a patient of ANCA vasculitis who had parotid involvement and left lower motor neuron facial palsy. You see parotid gland enlargement. With ANCA vasculitis, you expect leukocytosis, thrombocytosis. She had nodules in her lung, cavity nodules. A PET scan showed parotid uptake in the parotid and as well as the lungs. ANCA is positive, and ANCA vasculitis is that we should try to get tissue diagnosis as a parotid gland biopsy was done, which was suggestive of a necrotizing granulomatous inflammation with vasculitis. So she is VEXAS. She was given methylprednisolone pulse for 3 days along with rituximab, but the patient was lost to follow-up. She came back with severe abdominal pain, and she was worked up for whether it is infection or some other causes, and everything was negative. And it was part of disease activity. She had pancolitis, long segmental pancolitis. During the admission, she had neck stiffness with headache and fever. And an MR venogram was done, which showed an acute thrombotic occlusion of the posterior superior sagittal sinus, left transverse and sigmoid sinuses with extension in left jugular bulb. So this is a patient of active ANCA vasculitis, but we are given 1 dose of rituximab. So to look at other causes is very important. So we worked her up for prothrombotic states, pleural infections. So we got a CSF done, which was normal. All our infection workup was negative. Thrombophilia workup was negative. With active disease, patients are also prone to get increased thrombotic episodes. So, and this patient had significant bowel involvement, almost like an IBD. That by itself also is a cause, is a prothrombotic state. So we started this patient on anticoagulation and given rituximab again, and she had improved. And her MRI brain was repeated around 8 months later, and she had there was recanalization, so anticoagulation was stopped. A month later, she again came back with severe headache. And first thing that came in mind was that she had a thrombus, but it was normal. It was because of pituitary gland involvement, because of the VEXAS, active disease. It was very, very rare case of pituitary involvement in VEXAS. So venous thromboembolism, the incidence rates in ANCA vasculitis is 6.5 to 8.2%. It is especially in patients with active and severe disease. It is more common in EGPA Chuk-Strauss, then VEXAS, and then microcystic cholangitis. And risk factors include high CRPs, elevated creatinine, GI involvement, cutaneous involvement, and low proteins. So in vasculitis with thrombosis, we can use anticoagulation for a short duration of time, or say around 6 months period. But in patients of Behçet's, we have to be careful because they may have associated aneurysms which can bleed. This is a new disease in terms of, not new disease, but it has been newly identified, called VEXAS syndrome. Basically, it is V stands for vacuoles, which are often seen in cells identified in bone marrow biopsies from patients with VEXAS. Then E is basically for E1 ubiquitin activating enzyme encoded by the UBA1 gene, which is mutated in patients. X stands for the UBA1 gene, which is located on the X chromosome. A is for patients with autoinflammation. S stands for the mutations are somatic, meaning that they are acquired at some point in life and not inherited. So VEXAS syndrome is quite, they can present to different specialties. They can present to dermatologists with neutrophilic dermatosis. They can have vasculitis. They typically have ear and nose involvement, ear involvement. They can have lung involvement. So it can present to different specialties. And the important thing is that they can have bone marrow involvement. So basically myelodysplastic syndromes, myeloma, cytopenias. So if you get patient who has a ear and nose chondritis, and if it's a male patient who's above 50 and has an MCV of more than 100, then one should suspect VEXAS syndrome. Or if their MCV is not more than 100 and they have low platelets, again, we should suspect VEXAS. So anybody, any adult male with unexplained cytopenias, refractory to with persistent systemic vasculitis, we should suspect. Okay, just to summarize now. So in patients who have in patients of rheumatoid arthritis who have low hemoglobin with normal MCV and normal MCH, and likely to have anemia of chronic disease. If LDH genetic is high, then look for hemolysis. If there's low MCV and low MCH, iron deficiency, and work up accordingly. If the MCV and MCH is high in these patients, look for drug-induced causes. If that's not the case, look for folic acid and B12 levels and supplement. In patients of lupus who have low hemoglobin with normal MCV and normal MCH, look for hemolysis. So retic counts, LDH, bilirubin, haptoglobin. If that's if it is there, then do a direct Coombs test. Which, if it's positive, then it's autoimmune hemolytic anemia. Do smears, look for schistocytes. If there is no evidence of hemolysis, then this can be because of anemia of chronic disease. In lupus who have low WBC with neutropenia, recurrent infections, one may give steroids plus treat the infections. If there's no recurrent infections, there's no need to treat. Leukopenia with count less than 4,000 WBC, then we should treat the lupus. Lymphopenia less than 1,000, treat lupus. If the WBC is high, rule out infections, or it may be because of steroid induced. If it is not, then rule out other causes. So hematological malignancies, do smears. If the platelet counts are low, again, do a smear, look for schistocytes and TTP. If the HB is low, can be because of, and Coombs is positive, can be Evans syndrome. If the platelet count is high, rule out infection or inflammatory process or APLA, because if they have APLA positivity and they may have autosplenectomy causing high platelet counts. Pancytopenia, if they have high fevers, and obviously macrophage activation syndrome needs to be looked at, otherwise can be drug induced. And if we are not able to find a cause, then bone marrow to rule out leukemias, MDS, aplastic anemia. Thank you so much. I apologize for my voice, but thank you for bearing with me.
Thank you, Dr. Punit, for that excellent lecture. You were superb and fabulous.
Thank you so much.
We have got some Indian colleagues who are going to bother you with some questions. And first of all, I request our discussants. We have a raise hand sign. So I request all the discussants to please put a raise hand signs. We'll go one by one. Right. So if anybody has any question from our discussants, can just put a raise hand sign. We'll go one by one. Okay, in the meanwhile, we have a question from the chat box. We have a question from Dr. Neeta Radhakrishnan.
Okay.
There are reports of polymorphisms that predispose to MAS in rheumatological patients. Does treatment change if we identify underlying any genetic pathogenetic mutations or variants?
Thank you for that question. So if these patients who have the genetic mutations, they would be high risk of going into recurrent MAS. So these are patients where they would need to be on, and just typically in the setting of a systemic GI patients, they typically need to be on long-term treatment like anakinra. I'm not sure about if any other stem cell transplantation or something will help. I'm not sure about that, but these patients would need to be on long-term anakinra for sure.
Thank you, Dr. Puneet. One more question from the audience. Question from Dr. Mona Vijayaran. During evolution of patients for thrombocytopenia, APLA workup should be done upfront in which situations?
I think in all the situations, ITP comes, APLA workup is a must. So because it changes the management, right? If so, once the platelet count goes beyond a certain point, you would add these patients on antiplatelets.
Perfect. Thank you so much. Dr. Abhishek Patil, your question, please.
I think I put it in chat box also. In the first case, I think most of us would ask that. Dr. Puneet, excellent presentation. It was very elaborative. But in the first case, I think most of us have this in mind. Why did we choose dabigatran over warfarin in the first case that you presented?
Absolutely, yes. So as I told you, I've seen the patient twice. So once to rule out lupus, and once in the OPD, I had called the patient because I wanted to present this case. So the patient was staying nearby, so I called the patient. But otherwise, the decision to start dabigatran was not mine. These patients should have been on warfarin, no doubt.
Okay, that's okay. That's what I would have preferred with the current and the US.
Absolutely.
And second, Puneet, that patients with SL, that was a very interesting data you told. Etoposide working in a Sogia patient presenting with MAS, is it 8 patients data
8 patients,
you told?
Yes.
I mean, in children, pediatric population, it's more of a comment. It's very difficult, particularly in adolescent. Some of the lupus patients, juvenile lupus, can directly present with macrophage activation syndrome. In such cases, it may not be able to, if a patient is like your case, well-established SLA, then presenting with MAS, it's a easier scenario. But when a patient present directly with MAS, should we adhere to the HLH 2004 protocol with DEXA and if required etoposide over giving methylpred, IVIG or biologicals?
Correct. It's a very good question. So I think if it's part of MAS, before going to etoposide and all the other therapies, the HLH, we would give like how we treat, so pulse steroid with cyclosporin plus minus IVIG, and that would be the first approach to these patients. And obviously, the diagnosis would be a challenge if these patients present. We send off the antibodies. These tests take time, and it may not give us time. So, but if clinically you have the features of history of arthralgias and oral ulcers and those things of active lupus, then yeah.
So only with a pre-existing clear-cut patient meeting a criteria for lupus, you would choose cyclosporin and
yes. If it is because of lupus, then definitely cyclosporin, pulse steroids, and.
Okay. Thank you.
Thank you, Dr. Abhishek. MADMX.
Yeah,
I don't know your name.
Good afternoon, everyone. I'm Dr. Akhil Goyal, consultant rheumatologist at Manipal Hospital, Jaipur. First of all, excellent presentation, Dr. Puneet. My question is, in your second case of SLE, in which initially you attributed a case of full-blown SLE with the renal involvement and everything, with the ferritin of approximately 2500 and pancytopenia. So you attributed it to actually early MAS. And we started her on steroids, high dose, and cyclosporin. So my question is, this can be there in just SLE also with renal involvement. So we should have started straight away with cyclophosphamide, considering she's having class 4 lupus nephritis, full-blown SLE, and with high-dose steroids. So what's your opinion on that?
Yeah, thank you for the question. So in the ferritins were quite high. It was, I think, 8,000. It wasn't 2,500. It was 8,000. She had other features. You had an ESR of 12, active disease. So in terms of acutely, what is going to, sort of kill her is going to be the MAS. So that's why pulse steroids, the cyclosporin, I wanted to get the counts up, stabilize the MAS aspect. She was spiking high grade, she had high grade fevers and everything. And then week 10 days later, I gave cyclophosphamide. So with pulse steroid, the nephritis part and all, sort of may stabilize to a certain extent. But the MAS part needs to be treated immediately. That is something which will not give us time. So that's why I chose cyclosporin with methylpenicillin upfront, and then switched her to cyclophosphamide.
Okay, thank you.
Thank you so much. Dr. Chandrakala, ma'am, your question, please.
Yeah, thank you for wonderful presentation. So it's continuation with the same question what the previous speakers. It's so sometimes it becomes difficult to differentiate between the SLE flare and the MAS. See, SLE flare also we have seen thousands of ferritin, 10,000.
The fever pattern changes to high grade spiking fevers in MAS compared to lupus, which is generally a low grade fever. Secondly, in terms of differentiating MAS and disease flare, you can have overlaps also. There can be a gray area. You can have both in combination. With regards to the ESR, so that's a clue, and CRP also the clue. So CRP will not be much elevated in active disease of lupus, and that we generally use it for differentiating lupus flare and infection, but it can also be used for MAS because it will go up in MAS, and if you rule out infections and site counts are going down, then something that we have to keep in mind.
You start both steroids and cyclosporin together, or do you prefer IVIG if you're suspecting infection, underlying infection?
Yes. So if I'm strongly suspecting underlying infection, definitely IVIG is a good option till you get your cultures and other things there. In the case which I had initially, the CRP was not much elevated. So it sort of gave us time, and we saw the trend of CRP going up and the cultures coming negative. So.
Okay. See, am I allowed to one more question?
Yes, ma'am.
Yeah. See, if we had a patient, a young boy of 8 years, and he had a refractory AHM, means refractory to cyclosporin, MMF, IVIG, prednisolone, and he was found to have a lupus, skin biopsy showed lupus, and C3, C4 was low, and 24 hours urine protein was normal. His hemoglobin every 4th day or 5th day maybe was used to be low. So in such patients, when do you use Scleroderma or any other drugs, like newer drugs in AHA with underlying SLE?
Right, ma'am. Ma'am, have you tried rituximab, ma'am?
Rituximab has been tried. Yeah, rituximab has been tried. But still hemoglobin used to be around like 5.6, and DCT is strongly positive. So such a young boy with skin involvement also. Okay. So what's your experience on sirolimus? Have you used?
No, I have never used.
Okay.
Yeah.
Can I make a comment?
Yeah.
I think even in this, antiphospholipid also should be looked at,
Yes, absolutely.
When you have,
yes.
And I mean, Puneet, it was really a wonderful cases that you presented.
Thank you so much.
I just wanted to say that in all cases, you've already made the comment, but I just wanted to say it to the hematologists that we need to look at antiphospholipid in all cases of cytopenia. And sometimes if you have a bad antiphospholipid, it becomes more refractory to treatment, the AIHA or,
It was done in this patient actually.
Right. And then, of course, ultimately, if nothing works, I haven't used sirolimus. But in some pediatric patients, I've faced this severe cytopenia. And in a couple of patients, a splenectomy was done, ultimately. So that was one of the things that I had seen, And a comment about eosinophilia itself being a very strong risk factor for thrombosis, Puneet. In your patient with that eosinophilic vasculitis,
yes.
The eosinophilia per se itself, apart from the vasculitis, is a very high risk factor for thrombosis. And I've had one patient with severe eosinophilia with extensive gangrene of the bowel because of thrombosis.
Okay, very interesting, ma'am.
Right.
Thank you, Chandrakala ma'am. Dr. Aditi Shah, your question, please. Dr. Aditi.
Thank you, sir. So my question is, we had a young male around 18 to 20-year-old, alopecia universalis with thrombocytopenia and neutropenia, which we attributed to autoimmune thrombocytopenia and autoimmune neutropenia. Responded to steroids, and then we added as a steroid sparing agent as MMF. But we had also read a few case reports of JAK inhibitor with tofacitinib. So what is your comment about it, sir?
This I'm not sure about JAK inhibitors, and
Okay.
in this setting, I'm not sure.
Okay.
In the cytopenias, if anybody else knows about it, can.
JAK inhibitor, I mean, tofacitinib is one of the drug of choice for alopecia areata.
Yes,
Yes,
But
in alopecia areata, it is,
yeah,
yes.
but about the cytopenias, even
I'm not sure.
Right.
So alopecia. So I had a patient of alopecia areata with ankylosing spondylitis. So I gave
Right.
JAK inhibitors, and a lot of the hair came back.
Right.
Thank you.
Thank you, Dr. Aditi. Dr. Akanksha Garg, your question, please.
Yeah, thank you, Dr. Puneet, for the wonderful talk and the case discussion. So my question is regarding patients who present with thrombotic microangiopathy. So do you think any particular rheumatological disorders need to be ruled out, especially in the females who present with this particular entity? And, sometimes they end up having recurrent thrombotic microangiopathy. So any rheumatological disorders we need to work up for the patient for?
Thank you for the question. So in terms of the TMA, so we have to look at we have to work up for APLA, work up for lupus. Also keep in mind that scleroderma renal crisis can present with a TMA also. And as I mentioned, these are patients who have, you will see that they are proper scleroderma patients. They will have extensive skin involvement and aggressive skin involvement. So, so basically, the lupus workup and workup for APS, and if you suspect clinically, then scleroderma. If everything comes negative, you can still send over scleroderma antibodies also if you're suspecting scleroderma renal crisis. As I mentioned, that there are some case reports where it can occur before the skin involvement.
Thank you so much.
Thank you, Dr. Akanksha. Dr. Gayatri, your question, please.
Good evening, good morning, everybody, and thank you, Dr. Puneet, for wonderful presentation. So I had asked actually two questions, but I saw this 60-year-old female recently who had gangrene of toes, and her HB was 17, platelets were 6 to 7 lakh, and ESR was 50, and she was referred by in-house hematologist. I work in Dinanath Mangeshkar Hospital, Pune. So she, her JAK mutation came positive. Still, because of gangrene, and she had some non-specific arthralgia. Her ANA was done. ANA was strong positive. ENA came positive. It was borderline positive for KU antibody. But her APLA workup was positive for LAC, beta 2, and ACLA. So beta 2 and ACLA, both IgG were positive, and LAC was also positive. So she was obviously on antiplatelets, etc. And so I gave her actually steroids and azathioprine, and she responded wonderfully because the gangrene was just started. So we always feel that since her ANA was also positive, I mean, we thought that it could be a endothelitis. I labeled her as undifferentiated CTD, but I have not seen many APLA with thrombocytosis. Obviously, she had JAK positivity also. So could we just routinely do ANA in all these hematological malignancies or hematological pre-malignant conditions?
Thank you, Dr. Gayatri. Very interesting case.
Yeah.
Very odd for a 60-year-old female to have APLA positivity and all these multiple antibody positivity, and to come with this digital ischemia and all these kind of symptoms. I think working up for paraneoplastic would be very important in this patient.
Yeah, so sorry to interrupt you. So her PET was done, didn't show anything, and her bone marrow also obviously was done because she was referred to me by hematologist, and bone marrow was also reactive. It didn't show a presence of any malignancy. So even I was confused, and I just started on because of that pre-gangrene and a lot of pain. We waited for her symptoms to just go with, but he himself wanted me to start on some immunosuppressive treatment. But she's responding well. She's coming for follow-up regularly, and her gangrene is almost gone. HB and platelets are in normal range. So even I have not come across any such case before this.
Yeah, usually you suspect cytopenias. So we would look up for CTDs when we suspect cytopenias. As I mentioned, that this one thrombocytosis can be part of APLA if their spleen is autosplenectomy. Otherwise, cytosis is not part of. Very interesting.
Okay, yeah, sure. Thank you.
Thank you, Dr. Gayatri. Dr. Rita,
Amit, can I comment?
Yeah, please.
Dr. M.B. Agarwal.
Hello, yes, sir.
Hi. Puneet, first of all, congratulations. Wonderful presentation and wonderful question answer session to you and your colleagues from rheumatology. Just a comment on this last patient. This patient was JAK2 positive, so it is clear-cut polycythemia vera, high platelet, high hemoglobin are all part of his myeloproliferative neoplasm. I must say that whenever we get a gangrene or any vascular symptom in this situation, we take it as a part of polycythemia vera. We don't usually investigate for other thrombotic disorders, genetic or acquired. So I won't be able to give you the statistics, but this is a very anecdotal case because even the whole literature of polycythemia vera hardly ever mentions that there is a common occurrence or you have to investigate these patients for APLA or any other prothrombotic disorders. Yes. And then they need lifelong anticoagulation once there is an arterial event due to polycythemia vera together with control of polycythemia vera. I would take this thrombocytosis as a part of her polycythemia vera rather than reactive. But wonderful case, wonderful.
Sure, sir. Thank you.
Thank you, sir.
Can I ask the panelists about one case that we are seeing at the moment? And yes, she is an elderly woman, about 55-60-year-old.
Yes,
and she has hemolytic anemia, but she's negative for Coombs, repeatedly done. However, her other reports and her hemoglobin keeps dropping. I mean, she needs transfusion almost very frequently, twice a week or so. Hemoglobin drops from 10, 12 to suddenly to 5, 6. But she's repeatedly negative for Coombs. So she's a Coombs negative anemia, hemolytic anemia. And now her ANA is positive with her SSA being strongly positive. But interestingly, because her globulins were low, we just looked at her immunoglobulins and the IgA and IgG is very low. Overall globulins are low and IgA and IgG. So could that be the cause for the Coombs negativity? I mean, what? And in spite of being at 55 years, she doesn't have a strong history of infections or, in the background. So this was a bit confusing as to how we should interpret the low globulins in this patient.
That I think Dr. Agarwal sir can answer this question.
Yeah, I wanted his comment on that.
Yeah, thank you. Acquired immunodeficiency disorders lead to immune complex diseases. So yes, that's one. Suppose IgG must be significantly low in this patient.
It's 340, yeah, 340.
So it was very, very significantly low. Second, what was surprising was that Coombs was negative, but the antinuclear antibody was positive.
Yes, strongly positive, sir.
Patient has capacity to produce the antibody, including an autoimmune disease. There are lots of reasons for why an antibody detectable by Coombs test can be negative in a given case, including that the antibody may be of a different type, like IgA instead of IgG, and you may not have a sera that detects that. The titer of the antibody could be low. Sometimes the antibodies are not exactly on the RBC membrane. So about 15% of patients of autoimmune hemolytic anemia may have life-threatening hemolysis with no antibody detectable by the standard Coombs test. So that's not surprising. And in hematology, we accept that and treat them exactly in the same fashion as Coombs positive.
Can I comment?
She's received rituximab, sir. But I just wanted to know how you interpret the low globulins in her case.
I think this is an acquired immunodeficiency syndrome.
Probably this patient is having, she's evolving CVID, combined variable immunodeficiency, and she's presenting only with autoimmune manifestations at present. She may develop infections later. Like these patients with CVID, they have all the three features like infections, autoimmune diseases, and malignancy. So in fact, like we were discussing sometimes like young patients with ITP and AIHA who don't have any background evidence of autoantibodies, there we should screen them for hypogammaglobulinemia and immunodeficiencies like B-cell immunodeficiencies.
The only thing is her age, which is she's almost 60 years. So it's a bit unusual. That was the thing. So anyway, this is also what we thought about, but her age is something which is a little
right. What
odd.
the previous speaker said, that in children and young people with autoimmune hematological disorders, we invariably look for the genetic primary immunodeficiency conditions, and in elderly people, there could be the acquired ones. It's a bit not unusual. If your IgG is so low, I was not sure the sequence of event. Was rituximab given and then all this IgG was done?
No. It was done because her globulins were low in all her reports. So we did
unrelated to
rituximab.
Yeah,
and then we gave her rituximab after that, of course.
So in adult practice, when we get these patients of IgG low, a good number of them to us come as immune-mediated ITPs or autoimmune hemolytic anemia or complex conditions. Yeah.
On an average, the mean age for diagnosis of CVID is 20s to 30s. So sometimes, like we see the bell-shaped curve, some patients are sometimes diagnosed in their 40s or 40s. 60 is little late.
Yeah, that was the odd point. And
Yes.
no past history of any infections, T-cell related, lowered immunity.
3 patients initially cytopenias, lupus-like manifestations, got all the, because globulins were low, got evaluated her at PGI Chandigarh, and she like had that CD27 deficient memory cells and classic CVID. She never had a single infection, and probably lupus-like manifestation, developed lung cancer and died within a period of 3-4 months. She never had an infection but proven CVID. So she was diagnosed at around 45, and maybe we lost her by 50s. So maybe something on that spectrum.
Yes.
Thank you, Dr. Pooja. One question we have from.
Can I make a comment?
Yeah. Please.
Yeah. Now, a word of caution actually with a diagnosis of EGPA, eosinophilic granulomatous polyangiitis. Actually, the disease has 3 phases: asthma, eosinophilia, and vasculitis, and they can be differentiated by time span of months to years also. So, a patient may have eosinophilia at some point of time, later develop years later vasculitis, and may have history of asthma, which may date 10 years back also. So it may not, all the 3 things do not occur at the same time, and that is why their diagnosis quite often becomes a problem, especially so because by the time if say vasculitis develops and the patient, almost 50-60% of them, they develop even cardiac involvement. So cardiac involvement related dyspnea, and then like it may be confused with respiratory asthma thing, which was many years ago. The treatment is not just steroids. One has to use steroids sparing immunosuppressants as well. So the patient which was told is decreasing tapering dose of steroids and currently on 10 mg of prednisolone, I would have added another immunosuppressants to the patient.
Thank you, ma'am. One question we have from audience, Dr. Karan wants to ask regarding the first case. I think it's a repeat of the thing. Dabigatran was given, but for apply-associated thrombosis, warfarin seems to be superior than dabigatran. So why was dabigatran given there?
No, I had not started it. Somebody else had started it.
Okay.
The drug of choice is warfarin. The take-home message also was warfarin.
Yeah, one more comment about catastrophic antiphospholipid antibody syndrome. I mean, I have really never had difficulty in differentiating it from a TTP. But occasionally, if it is a secondary APLA in a patient of SLE, there could be this problem of differentiating CAPS versus TTP. But the happy thing is, luckily for both the patients in emergency situation, the treatment is giving methylprednisolone and Plex. So,
true. One question from audience again. Dr. Shubh Purohit wants to ask any specific cutoff for platelet count below which we should stop oral anticoagulation to the patients of APLA with thrombosis. Cutoff for the platelet count.
50,000 be the cutoff.
Absolutely perfect. One more question from Dr. Abhishek Patil. He wants to know that is the first case, again the same thing, why dabigatran was offering. Again, Dr. Rohini Samant wants to ask, eosinophilia itself is a risk factor for thrombosis. Is it right? We have already, Madam has also said the same thing. Dr. Dheeraj, your question, please.
First of all, thank you, Dr. Ambedkar sir and Dr. Puneet. Very excellent, exhaustive talk. We covered a lot of topics. I want to ask the same question as one of the audiences, Dr. Gaurav Deshpande. So suppose you have bad leukopenia or neutropenia in SLE or any other rheumatological illness, and you need to give a immunosuppression. How do you go about it? And you have what? Only steroids or thing, and then or HCQ, something like that. Other immunosuppressant will create more problems or risk of infections. So that's the sometimes a worry.
Thank you, Dr. Dheeraj, for the question. So it depends upon what is underlying disease that we're dealing with. So that's number one thing. Are we dealing with lupus or rheumatoid arthritis or something else? Secondly, we have to find out why is the leukopenia there? Identifying the reason for it. So it could be part of your disease activity as part of lupus, or it could be drug induced, could be infections, or marrow failure, or some other lymphoproliferative conditions. So we have to evaluate what is the reason for it. It could just be simple like B12 deficiency, whatever it is. So we identify the situation and then we treat accordingly. If it is because of disease activity, and we need to give some agents. Now I'm talking very broadly. Drugs like cyclosporin can be used, so it doesn't suppress the immunity. But if it's part of disease activity, you will give steroids, and along with that you will add immunosuppression, because the steroids, the counts will go up if it's part of lupus.
Maybe mycophenolate also can be a.
Yes.
Can I ask a question?
Another just sorry. Yeah. Go ahead.
Yeah, just small experience.
Yeah, please go ahead.
Hello, the connection is lost.
I think the connection is lost. Ma'am, you can.
Can I just?
Sorry,
there is one. There. Oh, sorry. Go ahead.
Yeah. In patients of pancytopenia, I recently had an experience where everybody has thought of increasing immunosuppressant and giving steroids. The patient actually had some lymph nodes, and when we had the lymph node biopsy, it was teeming with atypical mycobacteria, and actually it turned out to be atypical mycobacteria causing pancytopenia in a patient of lupus, and she was thought as also HLH. So sometimes we can make a mistake of not diagnosing infections in such patients. So I think
true. Actually, maybe your patient had even extensive involvement with the marrow also, with the marrow also with mycobacteria, and marrow examination, unless AFB staining is done, it would not be picked up.
Yes, this was done because of the AFB staining only. So this is just to share the experience that we should not be very
absolutely.
Jyotsna, I was looking up macrophage activation. The first cause is tuberculosis.
Yes,
I mean the most common cause.
And even EBV.
So, EBV. So
EBV is a very common cause.
Yeah,
and actually, in continuation with that, the last question which was asked about genetic predisposition to HLH, and when there is no associated, say, rheumatologic condition, and there is genetic predisposition, I mean, we recently had a patient who was referred to us by Tata Hospital, and that time we had reviewed the literature, because often I don't think we know so much about HLH. So for that patient, this patient who had the genetic predisposition to HLH, EBV was positive, and what I recollect when we reviewed literature is such a patient should be treated with rituximab.
Yes.
Ma'am, I just, if may allowed, I can ask a question to ma'am. Ma'am, we talk about infection-induced HLH, but many a times the cause is not clear. Say, for example, HLH in a young girl presenting with some dengue positivity, antigen positivity, we think and treat it as infection-induced HLH with DEXA. But if the patient doesn't respond enough or adequately to that with DEXA and cyclosporine, can we go ahead and treat with etoposide in such cases?
Should be. I think a hematologist would be in a correct person to answer that. But then our patient was sent to us from Tata, and this particular patient was on steroids and cyclosporine and was not responding. And on giving rituximab, the patient improved. And I mean, of course, we started rituximab after reviewing literature, because we don't treat HLS day in, day out. So
yeah, EPP positive, yes, ma'am, there is.
Yeah. Yeah, can I ask a small question? Because everybody is more excited about HLH.
Yeah, just
the anemia of chronic disorder.
Yeah. Can I just come to you, ma'am? Just 2 minutes. Dr. Aruna Bhatt, your question, please.
Thank you, Dr. Mashru, for a wonderful talk and session. My question is to do with some of these kids, who evolve into SL from chronic ITP. They can have further thrombocytopenia itself as their main concern, with otherwise no other systemic involvement. And their platelet counts can sometimes come down very easily to 90,000, but they are otherwise really well. And it may not respond to azathioprine or MMF. And, at times during intercurrent illnesses, it may drop a little bit further down. And it may respond very well to slight increase in oral steroids. But my question is, what is the lower limit of platelets that you are comfortable with before you increase or put in other DMARDs, even other immunosuppressive agents, such as cyclophosphamide, because there's no other systemic involvement here. We are only talking about low platelets, which may quickly dip to lower counts if there is intercurrent illness, but otherwise it's okay. So what should be done in those situations?
Dr. Aruna, you're logged in from 2 sites. Close one because there is echo effect.
Logged in from one itself, but I'm wondering why is echo coming from. Sorry.
Okay, Dr. Khurana, go ahead.
Please, sir, you can answer the question. Dr.
Yeah, thank you for the question. So
I think the question is for a hematologist, Punit, isn't it?
Punit, go ahead.
Okay.
Yeah. So
you want to answer, or we can answer that?
No, I think please answer. We will learn from you all.
Basically, the thing what we keep the as hematologist, what we keep is around 20-30,000 is enough platelet count. 30,000. So if it is patient is not bleeding, platelet count is doing 20-30,000, it's fair on our side actually. Okay. Dr. Abhishek Patil, your question, please.
No, I think it was that question. I just, if time permits, I want one more thing. What is your experience on acquired hemophilia, sir? We have recently come across 1 or 2 cases. What would be your choice of, agents in such patients who have acquired hemophilia? There is a connective tissue disease with ILD doing well, suddenly started developing hematomas in subcutaneous tissues. And when we looked at EPTT, it was very prolonged. So we involved hematologists at that point, and we checked and we found that it is because of anti-factor VIII antibodies. So it was acquired hemophilia A. So what would be the second line agent? He responded well to retire. What would be the second line of agent?
So there's no clear. So there are case series in this situation. So I had one patient in the start of my practice, and this was in 2 months of my practice, where this rheumatoid arthritis patient presented with a hematoma in the thigh, and she was found to have APTT prolongation. So we that time pulsed the patient with steroids, and along with that gave cyclophosphamide oral. So the recommendation is around 1 to 1.5 milligram per kg of cyclophosphamide for 6 weeks, and then switch over to something else, or there's some reports with obviously rituximab and MMF also. The reports are there in the situation.
Okay, sure.
Thank you so much. Dr. Aishwarya Raj, your question, please.
Thank you, sir, for the excellent session and your talk. Basically, I've come across a case like 10 days back. In fact, 2 cases rheumatoid arthritis started on once weekly methotrexate and ended up with severe cytopenias, elderly females. So I just wanted to know one thing, because the second case directly was supposed to, I only managed. She had some baseline to start with before the methotrexate was started. The mild pancytopenia was already existent. Platelets were less than 1 lakh, and her TC total count was somewhere around 3,300, and HB was some 8 or 9. So, like, the decision to go for a MAP, because when she presented with post 2 doses of methotrexate, her counts dropped to 800. Platelet was somewhere sitting at 8,000. HB 5.6. So, and she's an elderly female. So, should we wait for maybe a week or after starting GCSF and the other supportive managements for the marrow, or like just taking her age and other, like the previous mild cytopenia thing? She was on HCQ for 3 years, and with that her rheumatoid arthritis was not like getting cured. So this had been started. So this decision for marrow, like what should have guided?
Okay, thank you for the question. So very interesting case. Number one, I want to know what was the creatinine at the start. So was the
She's a
creatinine
known type 2 diabetic since the past some 15-20 years. So creat had always been in the range of 1.73, and after metho it went up to 2.99.
Yeah.
So, and 2 doses, some 15 mg, I think, once weekly.
Correct.
So she just took 2 on 2 Sundays, and Wednesday or Thursday she lands up with all this.
Correct. So so we need to, obviously methotrexate needs to be stopped.
Yeah.
The folinic acid injections.
Yeah.
And GCSF, if the ANC is quite low or she's getting fever. But in spite of that, if she is not improving, then we need to look at other causes. You should also consider overlap of other connective tissue disease with RA. Okay, I had a patient of rheumatoid arthritis with an overlap of Sjogren's. So with ANA negativity and then at SSA positivity, was a methotrexate. I stopped the methotrexate, but the counts were still on the lower side. So then I did SSC and it came positive. So we look for other associated conditions. If there's no other cause for the counts and not improving, then obviously you'll have to do a marrow. But that decision is by hematologist. That's not.
But just sorry to interrupt. I mean, was GCSF given, like Grastim given before starting methotrexate in this patient? I mean, how come it was started with low? I mean, the decision to start methotrexate only was wrong when the counts were less than 4,000.
Yeah, because she came to like I received the referral only when her TC was like 800.
Yeah. I mean, luckily our patients keep quiet. Otherwise, the rheumatologist could be sued for starting methotrexate for such a low count.
So that, like her B12, all those other causes were like could HCQ be responsible? 3 years of HCQ?
What was her spleen? Does she have Felty syndrome?
Yeah.
This patient probably has Felty syndrome. If the primary diagnosis is rheumatoid only.
Yeah.
Yeah. And the other thing I would like to reinforce is that if the creat is high and it's an elderly patient, you know, the toxicity of methotrexate is very high, and the chance of it causing further cytopenia is extremely high. So really one should not with a low count in the first place, and the second is this high creatinine makes it doubly or 10 times.
And especially an
more
elderly
likely.
patient, instead of taking it on
patient.
Saturday, Sunday, they sometimes take it daily. They don't understand.
No, I ensured that only they showed me the strip only 2 doses on Sunday.
No, but with the creat high, I don't think you should have entered into methotrexate.
Yeah, absolutely. Wrong selection
So
of
for her
patients.
rheumatoid part, like what options does she have right now?
Multiple options are there. No, if the patient is not allergic to salazopyrin, sulfasalazine can be given to the patient. First, increase counts. You can give Grastim to the patient, increase counts, and then Smaller dose of methotrexate can be given, JAK inhibitors can be given, leflunomide, but the dose will have to be less than what a person with normal creatinine would be, and you have to be more vigilant monitoring the patient's CBC. Now, normal case, say you would call first visit at 1 month and then 3 monthly. Here you may have to call frequently for this, or you have to teach the patient how to look at on WBC count.
Thank you so much. We have got some questions from the audience. Dr. Ali wants to ask that are patients with rheumatological disorders at increased risk of developing hematological malignancies when compared to general population? Dr. Puneet?
Yes, thank you for the question. So, yes, answer is yes, and especially conditions like primary Sjogren's syndrome, they are very high risk of getting non-Hodgkin's lymphomas or maltomas. Then even rheumatoid arthritis patients, they are high risk. So the overall risk is significant. It's higher compared to the general population, definitely. In fact, even some of the drugs that we use may increase the risk of malignancies. Like JAK inhibitors, there's data coming in which is now showing there's increased risk of malignancies, especially so lung cancers and lymphomas are the predominant malignancies that can happen with JAK inhibitors.
Well, I think this question with Dr. Dheeraj Bhattad had already asked from same question from Dr. Gaurav Pandey. How common is to get isolated neutropenia in SLE? And if patient, what is the choice of immunosuppression for musculoskeletal cutaneous manifestation? I think that has been answered. One question has come from Dr. Ritasman Baisia. He wants to know that why DCT and AIHA kept separately in SLE classification criteria.
Okay, thank you for the question. So it is so it is so it's part of the classification. It's divided into laboratory as well as clinical. So if you are choosing a clinical parameter, then you don't choose the lab parameter. So that's why it is separate.
Absolutely, yes. Dr. Ritasman wants to ask when to suspect heparin-induced thrombocytopenia if patient with APS, antiphospholipid syndrome, with thrombocytopenia and thrombosis having heparin.
I think a hematologist can take this question.
So definitely heparin-induced thrombocytopenia, we have got certain criteria for heparin thrombocytopenia. We have got some 4T criteria which we follow. Usually what type of heparin has been given first, unfractionated heparin, what is the condition of the patient with the medical or surgical conditions, what is the duration when it was given. Usually between 5 to 10 days is the most common period when we suspect heparin with thrombocytopenia. And definitely what is the thrombocytopenia of the patient, what is the cutoff platelet count. So they have divided into less than 30,000, 30 to 50,000, more than 50,000. So depending upon the 4T criteria, we then go for the additional investigations. And that is how we suspect whether the patient can be heparin-induced thrombocytopenia or not. Another question which Dr. Madhumita wants to ask. That is, Ritasman has got one other question, that is baseline APTT prolonged a good indicator for APS?
I think it'll be present in all APS patients. In fact, you suspect APS when you see a prolonged APTT.
Okay, fine. Thank you. Dr. Dheeraj, you wanted to ask some question?
Just one completely different question from the discussion which is going on. In hematology, we are now going and many of the people excited about CAR T cell therapy. So what is it like? We are hearing all these things, earlier speaker about patient being on multiple diseases. In your case also, we found that mortality is also more with many of the diseases. So we'd like to have a cure, basically. So whether there's a role of CAR T cell therapy in rheumatology.
Thank you, Dheeraj, for the question. So it's very at an nascent stage. There was a case report of 5 patients of lupus who had very resistant disease, and they offered this treatment, and the response was 100%. And the median time when they had a relapse, or again they had to start the medicine was around 8 months. So it's still very early on, but it's something which is exciting and a possible, but it's quite expensive also in today's time, right?
So I didn't get it. So they were not completely cured. After 8 months, again they had to be restarted.
Yes.
None of our diseases are give any complete cure. So actually, there were some 10 reasons why rheumatologists are the most happy amongst all subspecialties given by American College of Rheumatology president. And one of the reason given was, that we develop a very good rapport with the patient. The disease is being chronic diseases. So there is no cure as such. It's like treating diabetes and hypertension. You control them.
So I had a very basic question.
Yes.
That erythropoietin, I mean, maybe the hematologist can answer. When would you actually use erythropoietin? In rheumatological conditions?
I think Agarwal sir can answer this question.
Yeah, for Dr. Agarwal.
Okay,
At
thank
least
you.
for anemia of chronic diseases. So.
Yeah, so thanks.
Yeah.
As you would know that this will be a lifelong treatment unless the reason for anemia is controlled. So if you've got anemia of chronic disease, it's not responding to the treatment of the chronic disease. And if you temporarily want to improve the hemoglobin because patient is getting decompensated, this could be a blood transfusion sparing agent. The increment can be maximum about 1 to 2 grams at the risk of developing hypertension and thrombosis. So we use it very, very rarely. Temporary, expensive, risk of hypertension, thrombosis, and would continue if the basic disease is not treatable.
So you would not really recommend its use at all, almost?
We will try to avoid it as much as possible unless a gram or 2 increment of temporary period is going to help the patient in getting into a compensated cardiac situation.
Okay. Blood transfusion might be better then.
So this is essentially to avoid the blood transfusion. True.
Dr. Josna, ma'am, you had a question? Dr. Josna, ma'am, are you there?
Asking. In patients of, for Dr. Agarwal, in patients of myelodysplastic syndrome, in patients of rheumatoid arthritis, with a persistent anemia, how do we manage it?
So myelodysplastic syndrome is very simple for us as hematologists. So a low risk myelodysplastic syndrome presenting with anemia, we do the EPO level. If the EPO level is below 500, erythropoietin is the first drug of choice in the doses of 40,000 to 60,000 of erythropoietin every week, or 500 of darbepoetin every 2 weeks. Minimum for 2 to 3 months. If the patient responds, we continue the same dose and try to taper it sometime later on. As and when it fails, and the median of 18 months to 24 months, this treatment would fail, we'll move on to the next agent. About rheumatoid arthritis and anemia, maybe you all can take over.
Okay, sir. Thank you so much. Is there any role of Actimra in these patients?
You're asking hematologist or rheumatologist?
Yes. No, up to you, sir.
Role of?
Sir, tocilizumab.
Yeah.
IL-6 inhibitor, because that has a role in, it really improves anemia of chronic disease in rheumatoid arthritis patient. And it will improve the rheumatoid arthritis part as well. Now, MDS part, whether what would be the effect, that is what I think she is asking, right? Right,
No.
Josna?
Yeah, absolutely.
So I don't think the drug has ever been tried. I don't even know of any case report of MDS.
Okay, sir. Yeah. Okay, sir.
Another very basic question, sir. Iron deficiency in Thal minor, how do you suspect it? Sometimes, we know that they have hemoglobins of 11 or whatever, and then we see a hemoglobin of 9 or
so
8.
All patients of thalassemia minor, if they come to us, we always do their ferritin and serum iron studies, because obviously you can't do anything for the thalassemia minor, but if they have associated low ferritin or transferrin saturation, then at least you can correct that part of it. And there are patients with 11 to 12 grams of hemoglobin, iron deficiency, you correct it and the hemoglobin can become almost normal. So obviously a patient who will come to us is a symptomatic patient. So it's a great relief to the patient. So almost all patients we do this.
But won't the ferritin be relatively higher in these patients?
No.
Because
Thalassemia
of the
no. Thalassemia minor is not an inflammatory condition. So ferritin low will invariably suggest iron deficiency only.
No, because of the turnover, will it not be a bit high?
No, not in thalassemia minor. That's for intermediate and major.
Okay. Sir, one question to you. How how often one would get avascular necrosis femur neck in sickle trait? Meaning, I'm asking this question because there were two brothers who actually presented to me in my clinic at the age of around 25, 30, and both of them hemoglobin was good, like 12, 13 hemoglobin, sickle trait, and both of them had avascular necrosis femur head. So like I was really surprised.
So, no, Yosna, depending upon the prevalence of sickle cell trait in a community, you will see more and more patients of ischemic events, and avascular necrosis is well described.
So even the traits, not the sickle cell disease.
We're talking only of trait now. So almost everything that happens in a sickle cell disease, depending upon the prevalence of sickle cell trait in the population, is described. It's anecdotal, it is rare, but happens. And therefore in US, these patients are not allowed various kind of jobs. And it's a huge political problem because 11% of the population is Black there. And they're being barred from military, they're being barred from being pilot, they're being barred from so many things because they can get anything that a sickle cell disease person gets. The prevalence is extremely low, but they get.
Okay. Thank you, sir. Really nice discussion. So thanks a lot for inviting us. I mean, it really generated so many questions and so much of overlap between rheumatology and hematology. Nice.
Thank you so much.
More for Dr. Puneet. He's the prime speaker.
I think he did an excellent job. Really.
Yeah, he did a good job. Yeah.
Thank you so much.
Dr. Gayatri, you have a question? Oh, okay. One question has come from Dr. Aruna Patel. The last question, your experience with danazole in thrombocytopenia.
I have not used.
For hematologists, we are using left and right anyways.
But Amit, you will agree that with L-Thrombopag and Romiplastin availability, use toxic drug like danazole has gone down.
Absolutely.
With 400 and 800 mg per day requirement over few months, and 70% of patients being female, it's a horrible drug, I would say. So I have stopped using it.
Perfect, sir.
Sir, good afternoon, sir. I just had one question. Sir, I wanted to ask to Dr. M.B. Agarwal and Sir Dr. Amit. Sir, in patients of refractory ITP, one case I encountered that a patient had CAD with MI 4 months back. And then after that, he started developing refractory ITP. He was given multiple steroids, azathioprine, MMF. So he was not improving at all. His platelet count was around 15 to 18,000. So then the question came of starting L-Thrombobag. But since L-Thrombobag has a side effect of stent thrombosis, so he was not willing for rituximab. So, sir, I wanted your opinion. Is it like the incidence of stent thrombosis or thrombotic events pretty high with sir L-Thrombobag and thrombopoietin agonist?
Amit, go ahead.
What this stent thrombosis for what actually was given?
Hello.
I didn't understand the question. Can you please repeat the question? Stent thrombosis for what?
No, patient coronary artery disease.
Okay.
And now there is refractory ITP. Will you use the TPO agonists?
Fine. So if the patient is having a coronary artery disease, stent has been put. Now the patient is of ITP. Definitely, we are using L-Thrombopag TPO receptor agonist. We are using. The risk of thrombosis per se has been very negligible. Even with both L-Thrombopag and Romiplastin, both basically. So I think there is no contraindication as of now to use L-Thrombopag or Romiplastin, that is TPO receptor agonist, even in patients who have got coronary artery disease with a thrombotic profile, because the risk of thrombosis per se has been well studied that it's very, very low.
Sir, even in patients who have got a PTCA done, the incidence of stent thrombosis, that was my main concern.
I may just add one or two sentences. One, yes, from the medical legal angle.
Yes, sir.
So one, because of this complication being there of the TPO agonists, one would be very careful in using them and take patient's consent to the ITP should itself be life-threatening, not just the low count. There are lots of ITP patients with 20,000 count, extremely stable, and they can be left alone. And three, why did he refuse rituximab, which is a very effective treatment for ITP? And many patients for a year or more can remain in remission, and they can take one dose of it. It's a very low dose of rituximab, not like lymphoma. So we just give one dose of 375 milligram per meter square. The efficacy works within about 1 or 2 months, and then it can last for a year or more. So if concealed properly, probably this patient can safely take rituximab. And for TPO agonists, one should take patient's written consent, because anything happens to him, even not related to these products, you can be into trouble.
So this dose of rituximab which you mentioned,
For ITP.
For ITP,
Yeah.
it's just one dose of
Yeah, so there are 3 protocols. One is one flat dose of 100 mg once a week for 4 doses. One is 375 milligram per meter square for a single dose. And one is you go all out like lymphoma doses and give 4 doses over a month. And there are now clear-cut trials showing that all 3 are equivalent. So don't have to use the lymphoma doses. 100 once a week, 4 weeks, 375 milligram per meter square, a single dose is as good as 375 milligram for 4 doses. And we don't use those doses which you use in SL, 1 gram, 2 doses, all that we don't require for ITP.
But for lupus-related thrombocytopenia?
So if you're giving it for ITP, that you use my dose. For SLE, you use
your dose.
Thank you, sir.
I think we are using low dose, sir. Just as
No, for ITP, yeah, I think sir had said long back, like, the lymphoma thing, there is so much of derangement of the immune system, then the high dose is required. For ITP, I think Indian hematologist said, tried a 100 mg dose long back. I think when rituximab came into market, our people are very smart, like, paisa to bachana hai.
And the new concept in ITP is a stable count of 20 to 30,000 is good enough to live for the rest of your life.
Yes, sir. We are doing the same thing.
Yeah.
Sometimes you have a lot of menorrhagia, sir.
Oh yeah, women is a problem.
Women. Otherwise also they are a problem, so you mean to say?
Anyway.
We use a lot of tranexamic acid. During
it's not an acceptable statement, but anyway.
I'm sorry, withdraw. So we use a lot of tranexamic acid during those 5 days every month. And if the woman is okay, we also use the hormonal pill. If there is no, she's not going to have desired pregnancy, etc. So hormonal pill, tranexamic acid, avoid immunomodulation can be the way for a stable ITP menstruating woman who has only menstrual problem.
For APLA, tranexamic acid is not a problem.
So APLA is a now different situation.
No, I'm just asking. I'm asking.
So you've got a prothrombotic disorder.
Yeah.
So that's a different situation. We'll be very, very conservative in using a thrombotic drug.
Right.
So anybody has any other questions?
Sir, I had one question to the hematologist here. So for hereditary angioedema that occurs in females, is there any option other than danazol? Now with the Celestrase, a C1 esterase inhibitor which is available, can we use it for prophylaxis other than attacks also?
I think sir can answer this. I really no answer.
So now, of course, the generic enzyme replacement therapy has become available. So that probably will be the preferred treatment. You're quite right. Danazol is extremely effective in controlling and reducing the attacks. I will not be able to often tell you, but I have only one patient with me. And when first this patient came to me, I went through the literature and there were certain drugs which were disease modifying. And this was some time ago, so I'm not able to recollect the names of those drugs. And those days, generic enzyme replacement was not available. So we had used something, but I will have to go back to the literature.
I think eculizumab is effective, works. I don't recollect. Yeah.
Cyclosporine or rituximab? I don't know.
Recurrent died, ma'am, but what we don't have many of those drugs. Danazol is effective in male patient, but I have a female patient where I'm finding difficulty with the side effects of danazol. So that's why I asked.
Just put a mail to me. I think there is a drug which is very strongly disease modifying, which I had used on this patient, but that was almost 7-8 years ago. And I lost that patient also, and I don't remember that name today, but there is a drug. Sure.
I'll mail you. Thank you.
Yeah.
Well, any other question? Fine. And I think the questions from the chat box are also over. And that was a fabulous discussion. And I thank Dr. M.B. Agarwal sir for joining in between, solving so many queries with so many questions aimed at hematologists also. Thank you so much for being the part of this webinar. I thank all the hematologists for being over here and making this webinar really successful one. I now hand over for the final vote of thanks to Intas Pharmaceuticals. Thank you so much.
Thank you, sir, and good afternoon, everyone. We have come to an end to yet another wonderful session on hematology of rheumatology disorders. I, Heli Gadani, would like to thank all the delegates for the continuous and consistent support in terms of their presence and patient hearing. Today, we witnessed a very insightful discussion, and I'm sure all the delegates would have learned a great deal out of the same. I'm thankful to all the experts for sharing their knowledge on this platform. I'm also thankful to Dr. Amit Khurana sir for wonderfully moderating the session. Last but not the least, I'm also thankful to the course director, Dr. M.B. Agarwal sir, for giving us an opportunity to be associated for this wonderful scientific platform. With this, I, Heli Gadani, sign off for today and wishing you all a happy Sunday ahead. Thank you so much. Thank you, everyone.
Thank you.
On behalf of Mumbai Hematology Group, I thank Intas for sponsoring our educational events. Special thanks to Puneet and the whole Rheumatology Group for making this so active. And thanks, Amit. Because of you, I'm in Kolkata attending the national conference and joined you in between from the last row. Thank you.
Thank you so much, sir. Thank you, sir.